Bismillah ar-Rahman ar-Rahim. We'll start our session under the title of Maternal Fetal Medicine. Our first speaker is Professor Khaled Ismail. Professor Khaled Ismail works at the Department of Gynecology and Obstetrics, Faculty of Medicine in Pilsen, Charles University, Czech Republic. He will talk about vaginal birth after cesarean section, what we call VBAC. How can women make an informed choice? Please, Khaled.
Thank you very much, Professor Ala, for your kind introduction, and thank you all for your attendance on time. So, vaginal birth after cesarean, how can we make an informed, how can women make an informed choice? This is the global cesarean section estimates all over the world. And you can see from the color patterns here, which countries have low and high cesarean section rates. And I'm sure you are aware of this. Egypt is certainly one of the countries with fairly high cesarean section rate. So this talk is really quite pertinent to practice in Egypt. Before we can talk about cesarean sections, because cesarean sections are not all the same, we need to talk about them in the context of this classification. It's called the Robson's classification. And the Robson's classification does not look at cesarean section as if it's a one entity. It classifies this cesarean section, depending on the group, into different types of cesarean section. This classification is adopted by the World Health Organization, the WHO. And more importantly, it is important to use this classification if you want to dissect or review the cesarean section rates within your unit, because based on which group is contributing most to cesarean section, you can then devise a policy to reduce your cesarean section rate if this is your aim. Okay. In these 10 groups, I would like to highlight 3 particular groups. One of them is group 1. And these are cesarean section done on nulliparous women who are in spontaneous labor. Somebody coming in labor, first labor for them, and they end up having a cesarean section. The other group are the nulliparous women who have a cesarean section either before labor, so somebody is having an elective cesarean section before even attempting labor, or the ones who have induction of labor, and this induction fails before they go into actual labor and end up having a cesarean section. And the third group that I want to focus on for this talk is group 5. These are multiparous women who have delivered before and they already have at least one uterine scar. So they at least had one previous cesarean section. This is really a very important study which was published in the Lancet Global Health in 2015. It gives an idea about the cesarean section patterns globally. It was done in 287 units, maternity units, in 21 countries. And in this study, they used 2 global surveys. The first survey was done between 2004 and 2008, and the second survey was done between 2010 and 2011. And they wanted to look at the cesarean section patterns between these 2 time points. I'm sure everybody here, you don't need to do a study, you will know that cesarean section rate is on the rise. So it's not surprising that the overall cesarean section rate in the first survey was around 26.4%. The second one was above 30%. So there is a rise in the cesarean section. These are graphs from this study. But these graphs are for the same units, but now they're classified depending on whether they are high, medium, or low income countries. And you can see in all these different countries, the biggest contributor of cesarean section rate are group 1, group 2, and group 5 Robson's group, which I talked to you about. So these are the biggest contributors to cesarean section rates globally. Reminding you again, group 1 are nulliparous in spontaneous labor who end up in a cesarean section. Group 2 are nulliparous who have a pre-labor cesarean section, and group 5s are the one who had a previous cesarean section. The question is, why are these the biggest contributors to cesarean section rates? Maybe because over time, the parity, the number of babies that women have also reduced. So the number of primips that are coming in labor is, relatively speaking, higher than or increasing over time than the number of multiples. Maybe because obstetricians are worried about being sued and medical legal problems. So the easiest way out is just do a cesarean section, get a healthy baby out, and that's it. Instead of having to worry about going through labor for a few hours and ending up with a problem. Maybe the maternal age is increasing. So a primip in 2004 who maybe was 25 or 26 years old, later on, a few years' time, because people are delaying pregnancy, maybe they are now in their late 30s or early 40s, for example. These are all possibilities. And of course, group 5, which are the previous cesarean section, is going to increase if we increase the number of primip cesarean section, because these women are going to come back again pregnant. The second cesarean section is an easier decision to make. What we call a dominoes effect. It's a reflection of what has happened before. But the other interesting thing when you look at the two surveys, so in these graphs that I showed you before, there was a dark line for each one of these groups, which was the first survey in 2004, 2008, and the lighter color is the second survey. If we compare the two surveys, we notice that the contribution of group 1 has increased slightly. The contribution of group 2, the pre-labor and induction of labor cesarean section, has increased a lot. And group 5, which are the previous cesarean section, has increased in middle and low income countries, but in high income countries, it has come down slightly, just slightly, still a big contributor, but it has come down slightly. So we need to think about why is this happening? Maybe the group 2 has increased because more women are asking for a cesarean section straight away. They don't even want to try anything. Maybe our induction of labor intervention is increasing and a lot of it is failing, and they end up having a cesarean section. Both of these are still in group 2 Robsons. Maybe the decrease in group 5 is because VBACs, vaginal birth after cesarean section, being offered to women is having an effect. However, this effect is not noticed in low middle income countries. We are in this category, we as in Egypt. So what is the current evidence about vaginal birth after cesarean? The evidence shows that it is clinically safe for the majority of women who have had one previous cesarean section. There is consensus amongst big bodies that produce guidance in obstetrics and gynecology, like the National Institute of Clinical Excellence, the Royal College of Obstetrics and Gynecology, the American College of Obs and Gynae, and the National Institute of Health, that it is safe. It has a huge economic benefit. It's interesting, actually, that the high-income countries are concerned about the health economic benefit, but the middle and low-income countries already struggling don't seem to be concerned so much about this. But it also has lots of health benefits, as we are all aware of the problems that happen with multiple previous cesarean section, not only operative, but what happened to people later on because of the higher risk of abnormally adherent placenta accreta and percreta. What are the contraindications? This is just information for you to understand really what is the current evidence. The contraindications to VBAC are things that we are aware of. If somebody has previously had a ruptured uterus, if somebody had an upper segment or what is previously known as a classical section, if somebody had complex uterine scars, so somebody had a big extension in the cesarean section, or if somebody has had previous uterine surgery. These are contraindications to offering a vaginal birth. There are certain situations where a VBAC might carry a slightly higher risk if the interval between the previous cesarean section and the current pregnancy is short, if it's less than 12 months, if the woman is post-dates, if the maternal age is high or there is obesity, if the pre-labor Bishop score or whatever tool you're going to assess the favorability of the cervix is showing that it's poorly favorable, then the risk of a VBAC is much higher. Or if there is decreased thickness of the myometrium on ultrasound scan. I have to highlight that all the ultrasound scan images that I'm going to show you in this presentation are care of Professor Rasha Kamel, who's a professor in the university, and she's amongst the audience and one of the speakers in this session. So this area that is marked with these two arrows is the myometrium that we are trying to measure. And there is actually high-level evidence that if you measure this during the antenatal period, if the thickness is more than 2 millimeters, so 2.1 or more, there is a strong negative predictive value for scar dehiscence or uterine rupture. However, if it is thinner than this, then there is a very high risk of uterine rupture. So it's something that we definitely strongly advocate. It should be measured before you start counseling your women about VBAC. This is, again, as I mentioned, these slides are from Professor Rasha Kamel, and this is a video just showing that the thickness of the myometrium could be either checked using an abdominal ultrasound scan, and it indeed can also be checked using a transvaginal ultrasound scan if you know how to do it and if the woman allows you. What are the complications? We are all obviously quite concerned that this woman could end up with a ruptured uterus. This is an example of a scar dehiscence here. You can see the bulge there, which I'm sure anybody who's practicing OBGYN would have come across this in some form of context. The risk of this happening is 0.5%, 1 in 200. This is another example of a uterine rupture, but this is a full rupture. The baby is totally in the abdominal cavity. You can see it on the ultrasound scan with the placenta and the uterus in the bottom left-hand corner, and the baby is already out. Sadly, this baby obviously was dead by that time. There are also other complications: perinatal death, ischemic hypoxic encephalopathy. The risk of this is really much less. So 4 in 10,000 compared to 8 in 10,000. And a significant number of these are happening again because of uterine rupture. There are some morbidities there. The risk of mortality is much smaller. It's about 4 in 100,000. So these are the figures that normally in Europe we discuss with patients before they make a decision. I'm aware that patients are different in different places, and by the time you mention any of this list to women in some countries, they might say, "Oh my God, no, I don't want this too." Of course, it also depends on how you say it, because we convince ourselves that we are very open and give patients information, but we subconsciously tell patients what we want them to do. VBAC management. If you are going to offer VBAC, you have to be very strict about this policy. You have to make sure that the woman is in the right place. So don't offer VBAC in a private clinic. You have to have facilities for things, just in case if things go wrong, either for mom or baby. You have to make sure that the woman has IV access. There is one-to-one care, because somebody needs to be monitoring her, not necessarily you, but at least there is a midwife or an obstetric nurse with the patient at all times. You need to ensure that there is continuous electronic fetal monitoring, because if you monitor the patient with CTG, you can pick up early scar dehiscence fairly early before complications happen. And of course, somebody needs to monitor the progress of labor. And the progress of labor needs to be monitored as objectively as possible by whatever tool you have in your unit. And this is the current recommendation about counseling. So you tell the patient about the risk of uterine rupture. Of course, if the woman is in spontaneous labor, the risk of rupture is much less. So the 0.5% is the overall risk, but actually if the woman is already coming in labor or planning to wait for spontaneous onset, this risk could be as low as 0.1% or 0.2%. If you're going to induce women or augment labor, the risk becomes significantly higher. So avoid these if you can. The success rate is fairly good. If you think 70% is good, of course, different numbers mean different things to different people. We also need to think about if the woman has had a vaginal delivery since her previous cesarean section, because if she did, and this is her second VBAC, all these outcomes are much, much better, and all these risks are much lower. She has already done it before. There are 2 additional risks that you might not be aware of, and there are a few other risks that I'm going to introduce to you in a minute based on work that we've done in our unit. One of them is the risk of obstetric anal sphincter injuries, OASIS. This is higher in women having their first vaginal delivery as a VBAC. So a woman had her first delivery by cesarean section. Now she would like to try a vaginal delivery. So she's having a vaginal delivery for the first time, but as a vaginal birth after cesarean. Her risk of having an oasis is higher than a woman having her first baby vaginally. Just slightly, but they need to be aware of it. There is also a slight increase in the risk of operative vaginal delivery. And these are data from our unit. We think maybe the oasis is because of the operative vaginal delivery rate, or maybe because babies get bigger by pregnancy. So she's having her second pregnancy, but the first vaginal delivery, and the baby will be bigger than a woman coming for her first pregnancy having it vaginally. However, this study is showing that the risk of oasis is independent to the other risk factors. So this seems to be definitely a fact. But is this counseling enough? Is this counseling enough for the woman to make an informed choice or not? I personally don't think so, because there are other issues that they need to be aware of. One of them is the risk of perineal trauma, not necessarily obstetric anal sphincter injury, but perineal trauma in general. And women having VBAC compared to women having their first vaginal delivery seem to be at a higher risk of perineal trauma in general, as well as cervical laceration and cervical tears. This is something they need to be aware of. And these could possibly be related to the baby's size, which will be slightly bigger just because it's the second pregnancy or the third pregnancy. Another hidden harm is levator avulsion. This is when the levator ani detaches totally from its insertion into our hip bone. And of course, this is quite a serious issue. It does not cause a problem straight away, but these women can run into problems later on in life. Women who are going for a VBAC have a 1 in 3 chance of ending up in a levator avulsion, which could either be on one side or bilateral. And this study was published recently in the White Journal. This is just an ultrasound scan image of levator avulsion, and you can see, even if you don't know how to scan, you can see there is a star there. Unfortunately, when you do a scan, it does not bring you a star to tell you where the problem is, but you can see actually that part of this muscle looks as if it has been bitten off. Part is missing, which is, you can see here on the right-hand side, it's the patient's left-hand side. So there is left levator avulsion after VBAC. Levator avulsion is important because it's significantly associated to the risk of pelvic organ prolapse later on in life. Women who have levator avulsion have 4 times higher risk of ending up in a prolapse compared to women who do not have that. Not only prolapse, but also cystocele, which is a form of prolapse, but in the anterior compartment. All this counseling happened to the woman when she is pregnant. But can we do something about it even before the pregnancy? Can we start the discussion before the woman is pregnant so that she knows what is going to face her later on? And again, yes, we can. And I'm going to talk about 2 studies, one from our group, and the other one is from a group here in Cairo University, which was led by Professor Rasha Kamel and Professor Sharif Nigman. Both of them, again, as I mentioned, are in the audience. We can give women information about maybe potentially whether their labor will be long or not based on the type of cesarean section they had before. Did they have a cesarean section as an emergency cesarean section? Did they labor, or did they have it elective? We also can tell them about maybe their potential risk of having problems with their placentation, how adherent the placenta would be. And this is the study that I alluded to, published by Professor Kamel and Professor Neg and other authors from the UK. And in this study, they looked at the type of scar in women who have had a cesarean section electively and those who have had a cesarean section when they were in labor. And there is a big difference between both. We all know about it clinically, that when you do a cesarean section for somebody in labor, the uterus is already pulled up and thinned out, and probably if you go very low, you more or less will be cutting through the cervix or the very, very low part of the uterus. If you do electively, the uterus is not formed as an intrapartum uterus yet, so your scar will be higher. So a scar in a cesarean section that has been done electively will be higher, but also the risk of the scar having abnormal features like niches seems also to be higher. And this observation, it is really very interesting because hypothetically, maybe the women who have had an elective cesarean section before are at a much higher risk of having placenta accreta and percreta in future pregnancies. Of course, if women know this information, then maybe VBAC is not a very good idea for them, especially if you do scans on them and you find that they have problems already in their scar before they are pregnant. From our group, we also looked at the duration of labor when women go for VBAC based on the type of cesarean section they had before. And here, there is another benefit to women having a cesarean section in labor rather than elective cesarean section. Because if they've labored before, the uterus is more or less used to how to do things, and the labor seems to be quicker when they have a VBAC, which is really very important because everybody is quite twitchy when somebody's having a VBAC. You don't show it on your face, but your heart rate shows it. So in conclusion, VBAC is not one size that fits all. We have to individualize the management based on the type of cesarean section, based on the pre-pregnancy assessment of the scar, based on the intrapartum assessment of the scar, and how the woman perceives all these other risks of pelvic floor injuries that we talked about. Screening should start pre-pregnancy because when the woman is pregnant, she's already stuck really. She can't make a decision. She will have to deliver. And at that time, at many times, the easiest decision is to say a cesarean section, when actually it could potentially be harmful to her. Once you've had this discussion pre-pregnancy, you have to monitor your decision and be brave enough to change it to either direction, depending on what you find on your further assessments. All your decisions should be based on evidence, not on your experience or your perception, and try to take as objective measures as you can. For example, in this context, ultrasound scan. Nevertheless, the most effective policy in reducing VBACs and cesarean section is to target group 1 and 2 of the Robson's groups we talked about. So really think once and twice and 10 times before you offer a nullip, a cesarean section, because this is the only way you can stop this dominance effect we talked about.